Welcome to ARI 2024, Alicante Refractiva Internacional. This is a special cases with a special interest, and it's a pleasure for me to introduce Dr. Alina Gheorghe from Clinical Emergency Eye Hospital from Bucharest, and she's going to talk about DMEC in cases of poor visualization. So Alina, whatever you want, we are going to hear you.
Thank you very much. Thank you very much for your kind invitation, for your warm invitation. Actually, I know Dr. Agesa a couple of years back, and every time she welcomes me with a lot of warmness, and I'm sure that all of you are like this. It's an honor for me to participate. And I will try to talk a little bit about DMEC in cases, in complex cases, in cases with significant central corneal opacities and poor visualization. And for that, I have two cases this afternoon. Two old ladies with Fuchs endothelial dystrophy that have undergone a couple of years back, 2 or 3 years back, cataract surgery with IOL implantation without special demands regarding this surgery. But with severe chronic bullous keratopathy afterwards. With these cases, I would like to highlight a little bit the importance of and the physiopathology of all corneal layers when we have endothelius dysfunction. And the first case refers to a lady with important stromal fibrosis and important stromal haze. And the other one refers to the mostly involvement of the Baumann layer with the recurrent epithelial erosions. And here it's the first case. Preoperatively, you can see deep stromal fibrosis with these yellow stars, with a lot of corneal edema, chronic edema with fibrosis and some fibrosis and haze over here. 3 months post-DMEC, we can see persistent anterior stromal defect over here with some haze, but in spite of that, good visual acuity and good remission of corneal haze. On the OCT, you can see a little bit an irregular zone remained in the area with the Baumann defect, but you will see in the other patient more severe. And here is the case. You can see a deep stromal fibrosis that puts in demand the DMEC. I do DMEC after the debridement of the epithelium with an AC maintainer that helps me a lot. But in difficult cases with stromal fibrosis, I find it quite difficult to do it. But afterwards, with the help also of the intraocular OCT, the endothelial graft centration goes pretty smooth and pretty well. I try to center it a little bit far away from the area of the fibrosis, so I don't have a lot of rebubbling afterwards. These are some print screens of the surgeries with the unfolding of the graft. Although the visualization keeps getting worse, as you can see in this image, the intraocular OCT helps me center and put the graft in the proper position. The other case is, as I told you, of a lady, again with Fuchs endothelial dystrophy and that undergone cataract surgery a few years back, that now has a bullous keratopathy with a poor visual acuity of counting fingers, but with a lot of anterior stromal scarring and the involvement of all the Baumann layer. You can see here almost quite normal pachymetry, but on the slit lamp, you can see significant corneal edema. As you can see 3 months postoperatively, that the corneal thinning, it's more evident, secondary to the remission of corneal edema. And due to the involvement of the Baumann layer and the severe corneal erosions, the defect on the Baumann membrane, it's still present, and of course the cornea has irregularity. The visual acuity, it's good, it's nice, but due to this thinning and due to the irregularity that it's causing high order aberration, of course, the visual acuity, it's only satisfactory for our patient. Here is the film. I'm not gonna show the whole surgery. I'm just gonna show the defect that it's, of course, involvement in the optic area that causes the visualization performing the surgery. Of course, there's a lot of discussion to be done. The answer is if we can push the limits of DMEC. I think nowadays we can push the limit of DMEC doing a PDEC. But doing a PDEC seems very easy, seems very nice, but we have to have very young donors to perform a quite nice and good PDEC. So I think that pushing the limits of DMEC, it's okay because the still visual recovery, it's good even in patients with anterior stromal defect. Because in our experience, we have seen that in spite of long-standing corneal endothelial dysfunction and stromal fibrosis, corneal transparency is frequently achieved in these patients. The only problem, perhaps, it's more when the Bowman membrane it's involved, because then it can cause thinning of the cornea, thinning and irregularities that induce the patient's high order aberration, highlighting the fact that when regaining visual acuity, not only the transparency of the cornea is important, but also the shape. In all the patients, anyway, even if we are pushing the limits in DMEC, we have very good results with very good satisfactory for the range visual acuity and greatly reduced recovery time. Thank you.
Thank you very much, Alina. Beautiful cases, beautiful surgery, and I totally agree with you. This is challenging situations because you don't see well, but DMEC has very good results, and it's risky for the surgeon when you are doing the surgery, but I'm sure you will continue doing that in that cases, right?
For sure, then.
So thank you very much, beautiful cases, and thank you for stay with us in ARI 2024. Thank you very much.
Thank you.